Our Center of Expertise in Replantation is an emergency microsurgery and post-op hospitalization program for traumatically amputated patients for all of Quebec. And it's a center which has resource patients. As Marie-Pascale mentioned, these are patients who are interested in serving the organizations that help them, and they use their experience as patients as part of the replantation project. They've completed their rehab, and they're anxious to support people who are undergoing a similar process. They are full members of the care team, and they're mainly communication facilitators between the treatment team and the patients. And they really play an important role in improving the care to our patients at the center. Let me back up. I was going a little too fast. Just to speak about the premise of our project. Initially, all of patients who were being followed at the Hand Center for Greater Montreal finished their rehab at MUHC. And people from outside had to go to an external site, a remote site. Over time, we realized that there were inequalities in the treatment plans, and we came to the conclusion that might be peer support that was a determinant factor in terms of compliance with treatment to reduce post-traumatic stress and improve outcomes. So we developed a program to get patients involved on the clinical aspect. And I'm going to get Olivier to talk about how the project actually took shape. I'm Olivier Fortin. I'm a patient resource at the replantation program, and I've been there since 2014. In January 2013, I cut all of my fingers off on the left hand in a bandsaw. I also cut off a chunk of my thumb. So our hands are very important to our work, but I'm a creative person. This is absolutely key. It's also very important in our interactions with other people. So when the accident happened, my life was turned upside down. And there were a lot of things that were happening inside me that nobody was addressing. And that nobody could really understand. And there were things that I couldn't really understand myself or articulate. Towards the end of my rehabilitation, about a year later, I was approached with the patient resource idea. Oh, this is a new program that puts former patients with new patients together so they can talk about their experiences. And I thought, that's fantastic, because at the time, that was the thing that was missing. Somebody would come in and say, I've been through what you're going through, and be reassured it's going to work out okay. That would have made a huge difference at the time. So how did we co-create this model? We started with a series of interviews with patients. We recorded them and documented them. And then we analyzed and came to a couple of conclusions in terms of roles and responsibilities and the competencies of the patient resource and where they would intervene in the process, and so on and so forth. So that also enabled us to determine where we were comfortable and where we felt we were relevant, and how we could approach patients. Yeah, I've been going a little fast there too. Okay, as far as roles and responsibilities, we talked about a couple of things, but complementing the expertise of the team. This is very important. In fact, the resource patient or patient resources has been through the trauma and knows what kind of impact it has at all levels. So, and that's a complement to the treatment team's intervention. Overcome isolation. When you have a trauma of this sort, or any trauma, whether it be physical or not, you need support. And simply being in contact with somebody who's been through the same thing breaks your isolation and facilitates the rest of the readaptation process. and getting communication going with the patient so that they can better communicate with the treatment team and optimize the treatment that the patient's going to receive on the basis of what the patient's looking forward to. And the patient resource gives some idea of what's going to happen. We meet people 5 days after their operation. And it's often between that point and 3 years later, there's a huge difference in what you think you're going to be capable of doing or not. So it's when you can meet somebody who's actually been through it and recovered, this creates hope. And that's key at that process, at that point in the process. This is a tool that we developed. The various themes that are important to bring out in conversations with the patients. The aspects of their lives that can be more problematic. For instance, well, as patients, when you've been through it, it's easier for us because we're sensitive and we can draw analogies between our experience and theirs. Socially, what's going on? Do you feel that people are rejecting you? Are you ridiculed? And you could say, well, when it happened to me, this is what happened, and this is how I responded to it. And communication is a lot easier, and we can get a lot of information from them that wouldn't otherwise be available to the treatment team. Now, here are some stages of intervention. The patient's hospitalized, and 3 days later, we ask them if they're interested in having a meeting. At 5 days, if they're interested, I would go and see the patient. At the first, there's also always a briefing after the first debriefing or briefing with a member of the treatment team to know exactly what's going on. Then we have the meeting. It might take half an hour, an hour 15. And then we have another treatment team briefing to share our insights. At least that way, the team has the information that we think is relevant. And then we continue to meet 6-8 weeks, and then later. The major difference between the early meetings and later on, we can do a video conferencing and so on and so forth. It's a means of contacting people who are not in the Montreal area. Now, we can reinforce or strengthen the work of the professionals and help people with their rehabilitation. Often the rehabilitation lasts a year and a half, and sometimes you reach a plateau, and it can be very discouraging for some patients. So by being in contact with them on a regular basis, it really helps. So thank you very much, Olivier. Let's talk about how we integrated patient resources in our treatment team. The first thing, well, there's a whole process of integration. We select the people, we train them, and when we train them, we involve the main members of the team to be reestablish a contact and also share their role. Then there was a communication plan, which with memos, monographs, Facebook pages, and so on and so forth, which are excellent means of keeping patients and professionals in contact. And there were meetings with occupational therapists to acquaint them with the role. I've only got 1 minute left, I'm told, so let me do a giant leap right to the end. I just wanted to talk about a few potential solutions if we wanted to do something similar in another context or in another type of organization. We thought that it would be good to identify champions, patient partner champions, to mobilize collective leadership on the project. Then to provide for clinical participation so that professionals can choose the patients that they want to work with, have a co-management of research projects with the clinical team to ensure that there's stability in the project and that it can be ongoing, and also to evaluate the perceptions and to change the project from research to continuous improvement, because that's what we're looking for in the longer term to ensure the well-being of our patients. Something that, and this is a definite plus for our patients. And there's been a follow-up. We're going to develop, let me back up here. We're going to do a pilot randomized trial that's going to go a little further to develop our program with hospitalized patients. And we're going to use rehab and clinical and psychosocial indicators to demonstrate what the benefits are with a group of patients and a control group. Thank you.